lecture. All right, hello everybody, I'm Judy Aronchek, and on behalf of the Executive Council of the Association of Senior and Emeritus Faculty, I would like to welcome you to our virtual luncheon lecture series where we have great lectures and no lunch. We've managed for almost an entire year without a COVID-19 themed lecture, but we've changed that for today. And we are very, very fortunate to have Dr. Brennan, our infectious disease guru at Penn, with us today. Dr. Brennan has been at the Perelman School of Medicine for close to 35 years, first as an infectious disease fellow in 1986, then joining the faculty in the Department of Medicine and quickly transitioning to physician leadership. Dr. Brennan has been the Chief Medical Officer and Senior Vice President of UPHS since 2005. And has chaired innumerable, uncountable numbers of committees involving patient safety, infection control, emergency preparedness, quality assurance, and so many other areas related to patient care and house officer education. He has served at our institution in the city of Philadelphia, in the state, nationally, and on committees for the CDC. In 2008, Dr. Brennan received the much-deserved Alfred Stengel Health System Champion Award, and in 2010, he received the CDC Lifetime Achievement Award. And I will just throw in a personal reflection. As a thoracic radiologist at HUP for more than 30 years, I have so many great memories of Dr. Brennan in the days when clinicians actually came down and looked at x-rays with us, and PJ was always so willing to share all of his wisdom and his knowledge of infectious disease with all of us, taught so much about infectious disease to all of us. So thank you. For the past year, Dr. Brennan has been a major force behind the UPHS COVID response and has worked tirelessly to make UPHS a safe haven for patients and for healthcare personnel. He is chair of the Penn Medicine Internal COVID Advisory Committee and has played a major role in planning the testing program and testing policy at the university. He also advises local schools, school districts, professional and amateur athletic teams, and the Philadelphia Orchestra regarding COVID-19 matters. So I can think of nobody better than Dr. Brennan to talk to us about COVID-19 vaccine distribution.
Thanks, Judy. That was a very generous introduction, and I too remember fondly those visits to the radiology suite to review studies, and I missed them. So I'm going to share my screen now, and my intention is to go through some slides quickly as background, and then really leave lots of time for questions. So I apologize in advance if I go too quickly through the slides. I really want to leave about 30 minutes for discussion. Having said that, I probably have too many slides because there's a lot of background that I wish to give you. So I've titled my talk, "When Will I Get My Vaccine?" Because that's really what every question seems to boil down to. However the question is delivered, it often seems to be at the core of it. So there's the virus, and I just point out the red triangles on top that represent the spikes that are really the key to the virus unlocking the human cell and entering it and taking over the cell's machinery to produce more virus. And below you see Eric Young, our first recipient of a vaccine at Pennsylvania Hospital on December 15th in Zubrau Auditorium. I'm not going to say a lot about the pandemic itself. I'm sure you're familiar with the trends. For those of you who joined early, we were talking about them a little bit before the program began. This is the epidemic curve in Pennsylvania, and on the left you see the peak that we thought was so awful in March and April, but the daily average then was never more than about 1,700 cases a day, whereas in early to mid-December we hit more than 10,000 cases on average. And then had a second peak after the holidays in early to mid-January, and a fairly steady downward decline since then that I think is probably a little too soon to attribute to the vaccine, because we only started vaccinating in this time frame here around the time of the peak. but probably has more to do with our behaviors and the absence of a holiday gatherings following January. So this slide is from the CDC, and it was put together last summer. And each of these panels does not represent a time frame. It's really a phase. And I think if you look at this is where we still are in the limited dose availability phase. I think we could say that this is probably frame shifted a little bit to the right. If you want to think about it as a time frame, and this first panel being 2020, vaccine arrived at about this point towards the end of this panel. And I think we're going to see the peak in the number of doses that we get later in the second phase than we anticipated because of production issues and the government not ordering enough vaccine. So, I have felt throughout this, I'll tell you that in all the conversations that I've had with public health authorities, that the information that I get has bordered on rumor, frankly, because it's just so conflicting from moment to moment. The president says one thing, both presidents, the past and current, and Tony Fauci says something else, and then the city and state translate it in yet another way. But I think from what we're seeing with production and delivery, we can probably expect to have enough vaccine to reach everyone in the US population who wants it by mid to late summer. So I would say these curves should be shifted a little bit to the right. But right now we're still in a highly constrained supply environment where we're still offering vaccine to targeted populations, as I'll describe in a little bit. So to do this, the federal government really needed to rely on the apparatus of public health jurisdictions across the country, of which there are 64 different jurisdictions for the vaccines, 50 states, all of the territories, and 5 large cities, of which Philadelphia is one. But to actually execute the plan, private partnerships were necessary with distribution channels like UPS and FedEx, and administration programs through the private sector, primarily hospitals, and to some extent commercial pharmacies, relying on guidance and best practices that were established back here by the feds and then interpreted at state and local levels. So as I'll describe, each of these vaccine jurisdictions has relied on the federal guidance, but has made local modifications, and that's led to a lot of confusion, I think. So the plans under what was called Operation Warp Speed, nomenclature that has been abandoned by the new administration, the federal government contracted with manufacturers to produce vaccines. I think it's noteworthy that the technology that really enabled the rapid production of the vaccines was not part of Operation Warp Speed, but was really developed here at Penn and then exploited by the manufacturers and helped us get into clinical trials rapidly and bring us to the point of having vaccines by the end of the year. The manufacturer of the vaccines was to pair the ancillary supplies in kits to be delivered to distributors and then partner depots. And then the original plan was to distribute vaccine to all of these administration sites. And a number of these have since been abandoned. Home health agencies are really not delivering vaccine to any meaningful degree. Some federally qualified health centers are, but hospitals have been the major source, along with pharmacies, as I mentioned, of the vaccine distribution. And doctors' offices have really not been receiving vaccine, nor has there been mobile vaccination programs. You've seen on the news, I'm sure, mass vaccination efforts in some cities, and Philadelphia is starting to go in that direction. Mass vaccination is defined in the city as being more than 500 doses administered in a day. So it's mostly hospitals and pharmacies at the present time that are involved in vaccinating. So what does all this mean for Penn? Well, we're subject in Penn Medicine to 3 different vaccine jurisdictions: the City of Philadelphia Department of Public Health, the Commonwealth of Pennsylvania, and the state of New Jersey. And when vaccine was first being released in mid-December, the city was being allocated about 20,000 doses a week in the first phase for a city in which probably 1.2 million people will qualify for the vaccine. The lower age limit is age 16 for Pfizer and 18 for the Moderna vaccine. So 2-dose vaccines. At the outset, the distribution of the vaccine was prohibited from being transferred to other sites without the direction and approval of the Philadelphia Department of Public Health. So they didn't even want us distributing it from HUP, for example, to our other hospitals unless they directed us to do so. And they absolutely didn't want us to be distributing it outside of the city, and still do not want us to do that. The state behaved in similar fashion and has since taken down those restrictions across county barriers. So in the run-up to the release of the vaccine, we established a prioritization committee within our internal advisory group and identified our highest priority frontline workers. And back in mid-October, it was anticipated that we would have greater vaccine availability during the second and third quarters of 2021, and that would relieve the pressure to prioritize that we've been going through since the release of the vaccine. And I'm not sure that we'll see that in the second quarter. Perhaps by the third quarter, after the 1st of July, we'll begin to have relief of the pressure on prioritization. So the first doses were delivered on December 15th. This is the delivery to Presbyterian, and you can see here the pharmacy director, Shamini Kazbaker, putting the first Pfizer supply in from these transport boxes. It actually comes in this cardboard box on 50 pounds of dry ice. This is going in a -70 freezer, and vaccinations began there the next day. We have a freezer farm on campus where these 3 freezers are utilized. They can hold 12,000 doses among the 3 of them, and refrigerated -70. So Pfizer is, as you have no doubt heard, more stringent in its requirements for freezing and refrigeration to maintain the stability of the vaccine. But when the Moderna vaccine was produced and delivered, we were able to store it at higher temperatures, and when Johnson & Johnson is released, we'll be able to store that at normal refrigeration temperatures. So that will be very useful, I think, in terms of getting it out into community settings and doctors' offices. So I want to say something about the vaccine supply chain. And I'm thinking about the kind of emails that I've gotten and the questions that have been asked, and anticipating what you might want to know about. So we have these long-standing federal vaccine jurisdictions in the United States, 64 separate jurisdictions, as I described, states, territories, and large cities. The vaccine is distributed by CDC to each jurisdiction based on population and disease occurrence. And then the Commonwealth and states and cities set up their own distribution schemes based on a number of factors, including the ability of hospitals to handle the vaccine, and the incidence of disease in the county, and the ability of one system to administer vaccine. So how much vaccine we're actually getting out the door and into people's arms factors into how much vaccine we're going to get. So the city, as a separate vaccine jurisdiction, established an advisory committee, which I sit on, and it was convened to review and comment on those 4 bullet points that I show you there. The prioritization scheme that we've been using with modifications based on the National Academy of Medicine and CDC guidance. The prioritization within the 1B group, which is, I think, in a lot of ways, the most challenging group of citizens to vaccinate. It's a large group and involves people with a lot of underlying conditions and people who do work. I'll show you these groups in essential industrial sectors of society. And then the city and every vaccine jurisdiction was required to submit a plan to the CDC in October. And the Vaccine Advisory Committee was asked to review each chapter in that plan as it was developed. And then more recently, and even in the lead up to the release of the vaccine, there were significant discussions on equity issues and communication about vaccine hesitancy and how we could overcome hesitancy and deliver vaccine in an equitable fashion to the population of the city. So the status of the rollout is of the vaccine is as follows: 64 jurisdictions, about 72 million doses distributed nationally, and about 2/3 to 3/4 of those now administered. 39 million first doses administered, which confers partial immunity after a couple of weeks, and then only about 16 million people fully vaccinated. So that's about 5% of the United States population that is fully vaccinated. I mentioned earlier that the city was receiving about 20,000 doses a week initially. More recently, it's gone up to 25,000 doses, and Pennsylvania has been receiving 175,000 doses. And the administration announced this week that it expects those numbers to go up by about 20%. You probably heard on the news yesterday about some issues in the state with some providers taking their second doses and using them as first doses and creating a shortfall in second dose availability, which is really important to effectively complete a vaccine program. And so in the weeks to come, the state is going to shift some of the first doses it's receiving, those 175,000 doses, into the second dose supply. And I'm actually not surprised that this happened. There has been a lot of confusing discussion from the feds and the state, and even consideration in the city about doing just that, about moving moving second doses into first dose supply. We receive our first dose supply based on weekly orders. And then on a 24-hour basis, we have to report every dose that we've administered. And based on those reports, the second dose receipt is timed. So we don't order the second doses, they just arrived. They just arrive, and we set them aside and store them. But I can see how providers would mistake the second doses if they're not, clearly indicated as such, and just administer them. And given all of the discussion that's been going on, I'm not surprised that I've had to ask more than once myself whether the city wants us to use second doses as first doses, and it has not. So this doesn't impact Philadelphia, but it impacts our hospitals and practices outside the city. So as you know, two vaccines are currently available: Pfizer and Moderna, messenger RNA vaccines. And J&J will, I believe, be evaluated by the FDA next Thursday, I believe, for its emergency use authorization, and then should be approved and released in early to mid-March. Unfortunately, this is not expected to substantially increase our supply. There appear to be some manufacturing issues. The good news is it's a single dose vaccine, and as I said, can be refrigerated at normal temperatures, but it's only expected that about 1 to 2 million doses will be released immediately after the emergency use authorization. AstraZeneca will submit in March and hopefully be available by April. And thereafter, we're hoping that Moderna and Pfizer manufacturing will catch up and we'll have substantially more vaccine available in the April timeframe. So in Pennsylvania, this is about a week old now. You can see that as of Sunday, actually, about 1.3 million first doses of vaccine had been administered by the state out of about 1.6 million doses that had been received, and roughly a quarter have received their second dose in Pennsylvania. So in that regard, at least, Pennsylvania is doing a little bit better on second doses. But this snafu that I described will slow down the first dose administration for a bit. There's a lot of concern about how the vaccines are being distributed and whether this is a fair and equitable distribution. And it really all goes back to the manufacturing process. There still is just not enough vaccine to go around. This table represents, is in part from the Pennsylvania Department of Health website, which shows how many vaccines. The website actually shows how many vaccines doses have been distributed to various counties, And then using the county population, you can calculate the number of vaccines distributed to each county per 100,000 population. And when you scan down, you can see that Lehigh County has received a disproportionate share, not clear why. And Northampton County, nearby to Lehigh, has received 29,000. That's the second highest county recipient of vaccine. Philadelphia County is not on the state website because it's a separate jurisdiction. But based on the distribution to the city and the population of the city, I would estimate that Philadelphia is probably in the high 20,000s range of vaccines per 100,000 population, well behind Lehigh County and probably on a par with Northampton County. With the consideration being the size of the population and the occurrence of disease, you would think that Philadelphia would receive more vaccine from the feds. The other notable county on this, I think, is Delaware County. Delaware County is the largest county in the nation without a health department. There are plans to create one by January of next year. But Delaware County has about a 500,000 population, is only receiving about 12,000 doses per 100,000 population. So it hasn't received very much at all. Similarly, Lancaster County hasn't received much, nor has Chester County. So I can't make inferences on this. I'm not sure why that has happened, but there does appear to be some maldistribution of vaccine based on the face of it. So how is the vaccine administered? Well, we've used this in setting up our own distribution mechanisms. We've used this 3x3 table that looks at on the y-axis the risk of acquiring COVID-19 infection, and on the x-axis the risk of transmitting it to someone who's at very high risk. So that led us to prioritize, for example, people at the front lines who are taking care of transplant recipients, because they could transmit it to people who would be at very high risk. But we were also prioritizing, of course, people who are at the very, very front line, like emergency department personnel, and everybody who works in the emergency department: security guards, transport workers, pharmacists, nurses, aides, clerical staff, all of whom encounter patients in the emergency department, in addition to nurses and physicians. So that's how we arrived at our scheme. And those who fell in the fifth and sixth boxes over here were those who received the highest priority, and then we worked our way through the rest of the workforce. The next few slides speak to the city's prioritization scheme, which, as I said, is different than the state's and is different than New Jersey's. And at the top here, I have the time frame for this phase of the vaccination process. So this is phase 1A, and phase 1A is the phase in which we administered vaccine to hospital staff, emergency medical services, home health, outpatient staff, and federally qualified health centers. And then we were asked to support unaffiliated healthcare providers. So practices that were part of, perhaps on our hospital staff, but not employed by Penn Medicine. We vaccinated COVID testing staff, vaccinators, and anybody working in our clinical laboratories who could be handling specimens, and also those working in our research laboratories, which we felt were high-risk individuals, our COVID research laboratories. Long-term care facility staff and residents were handled, and prison staff were handled by the city of Philadelphia. So this is phase 1A. It began around December 15th, and I expect that we will be through both doses in phase 1A by the end of the month. We're cleaning up the last few thousand individuals who have to be vaccinated, and I expect we'll be done before March 1st. This is a table that the city asked its vaccine advisory committee that I sit on to rate. This was the city's 1B workforce. It's one long list of individuals, and you can see on here, higher education is listed here along with persons working in congregate settings. And I'm just going to pick out a few: grocery store workers and public health workers, meat production workers, and so on. And we were given instructions on a 3-point scale as to how to score these. And these are the results and how they were prioritized. So you may recall that there was an article in the Inquirer about a month ago that the headline indicated that Penn Med disagrees with city's guidance, or words to that effect. That was not true, and it was never true. At the time that the memo that was referenced there was circulated, this was the table of 1B that included university higher ed workers. So we were going by the table that was available in the city and using CDC guidance. And on the day that we released the memo, the city's guidance changed. And that's where the conflict came in. But there was no disagreement with the city, and it was never our intention to not follow city guidance. So I just wanted to clarify that point in case any of you were wondering why we were going off the ranch and doing something that was not indicated by the Public Health Authority guidance. We never did. And we've tried to hew very closely to that guidance. But eventually what the city did was break that table into 2 categories. 1B, which we began to work on in mid-January, and I expect will take us into March to complete. And the 1B table for the city includes people over the age of 75 and those with some high-risk medical conditions. At the bottom here in the fine print are all of the high-risk medical conditions that the National Academy of Sciences and others have endorsed, but the city only wanted us to work on patients with cancer, chronic kidney disease, type 2 diabetes, and solid organ transplantation, just those 4. We asked if we could add sickle cell disease to that. So those are the 5 conditions we've been working on in the city. The state of Pennsylvania, the Commonwealth of Pennsylvania, the state of New Jersey have used age 65 as their lower limit and have swept many more conditions into this, in addition to all of these other essential roles like first responders, people providing services in high-risk populations, public transit drivers, and so on, anyone involved in food preparation. I won't read all of them, but this is the 1B population. There are about 400,000 people in Philadelphia in that 1B population. Penn Medicine has about 800,000, and we're working through all of them to try to identify and vaccinate them. So I expect this is going to take us well into March to get that, or perhaps even into April until we finish that. And then the 1C population will probably kick in parallel, is my guess, as we start to get through 1B. One of the important issues, I think, is when do you stop trying to convince someone to get the vaccine? We have taken the approach that we're going to work very hard to overcome hesitancy, to address equity, and get as many people vaccinated as possible. But it's a long process. It takes a lot of time to get people to overcome hesitancy. And in the meantime, vaccine is sitting on shelves. And so we're trying to, address that tension between equity and speed to get as many people vaccinated as possible. And I expect that probably in the April-May timeframe, even though everyone in the 1B population hasn't accepted it, we'll start to vaccinate the 1C population, which represents persons over the age of 65 and these other critical essential worker roles in society. Now, in addition, back to 1B for a second, in addition, persons who qualify on the basis of age, if you have these high-risk medical conditions, then age is not an issue. So if you're 40 years old and have type 2 diabetes, or 18 years old and have sickle cell disease, you qualify in the 1B population. And then finally, I expect in the summer of 2021, of this year, that we will get to everyone who's over the age of 16 years and not previously immunized. So otherwise healthy people in the population, younger people in the population. So I think by midsummer, probably July or August, we'll be vaccinating everyone, and hopefully that'll put us in good shape to get into the fall and school activities and so on. So this is what's happened in Penn Medicine. I think were it not for the snow today, we would probably go over 100,000 doses administered across Penn Medicine at 6 hospitals and a few other sites. The orange-red tips on these bars represent the second doses, and the blue bars represent the first doses. So you can see the trend in the blue bars has been leveling off, and that's been our trajectory. So among employees, we've administered over 31,000 second doses so far. So 31,000 people are fully immunized. As we've turned to the public now, we've gotten about 5,400 people immunized as of Tuesday, and continue to work through the public. Public in our definition means anyone who is, anyone who is not employed by UPHS. So we have vaccinated students, for example, who are on clinical rotations, and that counts as public. But I'll also say a little more about what we're doing for the public at large. So for the public at large, as I said, the city has given us guidance that we have to restrict the vaccine that the city gives us to those with Philadelphia zip codes and to those 5 conditions that I mentioned previously. And using that, you can see on the map here, the darker shaded areas represent the zip codes to which our vaccine offers have gone. To date, going back more than 2 weeks now, we've offered about 40,000 shots. The uptake is much lower in the community than it is among healthcare workers. We've only had about 25% uptake so far. The dot represents the 19104 zip code where the main campus is, and Hupp and Presbyterian are located. But what this tells you is that the city's guidance is getting it into the communities that have been most heavily affected. This is where the offers have gone in this bar graph down here. Almost 50% of the offers have gone to the Black population. About 40% in the city have gone to the white population. And then you can see just a smattering to other demographic groups. And mostly those under the age of 75, only about 25% have gone to those over age 75, and then younger populations with comorbid conditions have gotten the rest. So this is a map on the left of the COVID positive cases that have come to Penn Medicine from Philadelphia zip codes. And the darker numbers represent more than 90 positive cases coming out of those zip codes. So here again is 19104, and you can see, if you can, think back to this slide, the places where we're offering vaccine nearly perfectly represents those zip codes where vaccine has been offered. The panel on the right represents the percentage of the Black population by various zip codes, and that too coincides pretty closely with where the COVID cases are coming from and where we are offering vaccine. Last weekend, we started the first of several vaccine outreach programs to churches in West Philadelphia. This is Phil Ocala being interviewed at the Church of Christian Compassion. We're not repeating that this weekend, but beginning the following weekend, every weekend, starting next weekend through April 3rd, we are booked at one or another site in the community to do 500 or more vaccinations. We think we can probably do in the order of 700 or 800. And you see some of our volunteers here who participated. So just to give you a sense of how we're faring in the city compared to others, this table is a little bit hard to read, so I'll just walk you through this. The upper part of the panel represents the hospitals in the city. Our health system is at the bottom here with represents all 3 hospitals, and we have administered 40,500 doses, more than double that administered by other health systems in the city. And overall, that represents 23% of all the vaccine that has been administered in the city. So nearly 2/3 of the vaccine in the city has been administered through hospitals, and we have administered about more than 1/3 of the vaccine that the hospitals have put in people's arms, but almost 1/4 of all the vaccine administered in the city. So I think our process has been efficient and effective, and if we can continue in that vein, we will continue to get lots of vaccines. So this is just the city. When you take into account the other hospitals, we're pushing 100,000 doses administered. So I'm going to wrap up here. I think this is my last slide, and then take questions. So our vaccination challenges are that we continue to have limited supply, and the infrastructure is limited for mass vaccination programs. We continue to run the health system and try to, manage the conditions, the cancers and heart disease and diabetes that we always do, but we're pulling people from those day-to-day roles to participate in the vaccine infrastructure, and there's more support necessary from really federal authorities to help us. The city doesn't have the means to do that, so we need more support to stand up mass vaccination programs. We're relying a lot on volunteers. The restrictions on distribution across political boundaries are coming down within the state, but not between the state and Philadelphia, and not between states. So that's still a challenge. The vaccination criteria is inconsistent across geographic and political boundaries, and that's certainly confusing to the public. And vaccination hesitancy is real. I think if we just open the floodgates and let everybody come in, we'd fill lots of slots, but there's still be a lot of people out there that are refusing to get vaccinated, and we're working on all the reasons for that. I'll be happy to describe those. And then the global emergence of variant strains and the challenge that may provide to our ability to achieve herd immunity is very real, I think, and only time is going to tell. So far, we've seen some people get infected after being fully vaccinated, but we haven't seen anyone become seriously ill. So that's the good news, and that's really what the vaccination process is about. So Judy, I'll stop there, and I'll be happy to take questions.
All right, I will just read the questions to you that are coming up on the chat.
Okay.
Is the chemical composition of the first and second dose the same?
Yes, it is.
Do we know whether vaccinated people can spread COVID?
We don't know that yet. We don't know how much. We do know they can become infected. We don't know how much they shed, but it's certainly plausible that they could infect others, and that's why we're continuing to maintain our public health measures, masking and distancing and hygiene and so on, until we know more.
Just to comment on that, one of the things that we've been hearing Dr. Fauci say is that they believe from a couple of studies that they've seen that the actual viral load within the nasopharynx of people who have been vaccinated is less than what a patient would have with a first infection. And so would that be significant in transmissibility?
Yeah. It will be. The variants are important because they seem to be more transmissible because they have a better fit on the receptor. And with the variants that have been circulating, it may take a larger inoculum to cause infection. So if you're shedding less virus, that may be a beneficial effect of the virus in terms of preventing spread of infection.
Does the time between the first and second dose matter?
Generally, yes. It probably doesn't matter out to probably 2 to 4 additional weeks beyond the recommended time frame. But after that, we just don't know. I mean, I've had that conversation with John Wary in immunology, and I know he's very concerned about delaying for too long. And that's what the state's proposing as a partial solution to the second dose shortages, pushing it back to 6 weeks from 4 weeks for the Moderna dose. That will probably be okay, but I'd prefer to see everybody get their dose on time.
Well, the federal government purchased J&J vaccine. Biden stated that there is sufficient vaccine already accounted for everyone with just Moderna and Pfizer.
Well, I haven't heard him say that. It's certainly not true on the ground. If it exists in the manufacturing plants, that's another issue. But my understanding is they're moving it out as fast as they can. We do know that the past administration and the current administration both announced that they were going to be releasing all their reserves, only to discover that there were no reserves in mid-January. So, my understanding is they're releasing vaccine as it comes off the line.
Here's a question that several people have asked. School of Medicine researchers who work with human samples are 1A, but have not received vaccines. How is the School of Medicine prioritizing these individuals? And when will these faculty, students, and staff be vaccinated?
We've received that question a lot, and we try to work through each request to understand exactly what the laboratory does, and to make a judgment and about whether they qualify under 1A or 1B. Otherwise, if they don't, they would qualify under 1C, which is higher ed. So we look at each one of these requests individually, and it's been a very thorny issue. I know there's been a lot of dissatisfaction about it, but we're trying to do this as equitably as we can across the essential worker population and the general population.
The next question addresses the disparity that you noted with Lehigh County getting 4 times as much vaccine as say, Delaware County. Who makes that decision?
That decision is made at the Commonwealth level. I don't really have insight into why those differences occur. I know that Lehigh County was planning on setting up a mass vaccination site, a drive-through site at Dorney Park. I understand that it was shut down after a few days there because they didn't have enough vaccine. I don't know for sure, but I have to think that Delaware County not having a health department has worked against it in advocacy.
Penn Medicine has not been good at communicating with its patients about vaccine availability. The website has not been updated in 2 weeks, and they do not send out confirmation of receipt of the vaccine interest form. Why has this not been addressed?
Well, we're working on it all the time. I'll take that under advisement, but the guidance has changed on a regular basis, and we're doing our best to work through the categories that have been described, and make sure that it's hard to explain that to people that you're a citizen of Pennsylvania, and you get your care at HUP, but you can't get vaccinated at HUP. So I think there's been room for improvement. I won't deny that, and we'll work on that.
The graphic shows that Penn Medicine Radnor has not administered any vaccine doses. Why is that?
Because we can't get vaccine there. The state is distributing vaccine through hospitals, and we don't have a hospital in Delaware or Montgomery County. This afternoon at 3 o'clock, I have a call with a call with Delaware County, and we're proposing to Delaware County, and we hope that we can enter into a partnership with them, where we will provide a vaccination site for the county, and we'll see what comes of that. We're lobbying the state to enable us to be a large-scale vaccination site, but the state's approach was to kind of really spread vaccine around. So they were giving vaccine to really hundreds and hundreds of locations, and I think that some of that probably contributed to the misappropriation of the vaccine, the inadvertent use of second doses as first doses. So they're winnowing that down now, and they want to just give vaccine to pharmacies and hospitals. So we're trying to get them to let us use the Radnor site and the Valley Forge site, and we've made an application to do that. They're helping us expedite that, and we hope through a partnership with Delaware County we can start to vaccinate there pretty soon.
Well, some of these are kind of repetitive questions. Will the recent Moderna shortfall affect upcoming Penn vaccine appointments?
It should not affect us downtown, because this was a a state issue, not a city issue. So I think we'll be okay downtown. We are moving vaccine around within the health system, and we have asked the city and told it, we've asked the city, cooperated with the city to move vaccine out to the counties with the promise that we'll bring it back when the county has a sufficient supply. So, if need be, we will backfill Chester County and Lancaster General for their second dose Moderna needs. Right now, we're in pretty good shape in the city, but it's really a moving target week to week. We don't have a very long horizon to understand what we're going to be getting. It makes it a real challenge to schedule people because we're never certain week to week how much vaccine we're going to get.
Is it known how long immunity will last following vaccination? Is it like the flu vaccine that must be repeated annually?
We don't know that yet. I expect we'll know a lot more. We think that the immune response to the vaccine is more robust than the response to the natural infection. And I expect by the end of the year, we'll have a much better idea of how durable the immune response is.
Why would that be? Why would the immune response be so much bigger to a vaccine than to a natural, especially if you get a large viral load infection?
It's not clear. It's not clear. It may be the ongoing generation of the spike protein. That's what the vaccine does. But that's a question I'd have to put to Drew Weissman, I think.
There are many questions from people in different laboratories that are asking about when they would be eligible for the vaccine. And I'm going to suggest that they contact you individually. But here's one. Our research laboratory members, graduate students, and postdoc fellows and technicians, some of whom work with human tissues and in buildings that provide patient care, have not been offered the vaccine. Their contemporaries at CHOP and the VA have been vaccinated. This disparity is frustrating and producing anxiety.
It is frustrating. I have to tell you that some organizations have not followed the guidance. I'm not making any inferences about CHOP or the VA because I don't know the specifics, but I do know that some organizations have not followed the guidance, and we've had it thrown up to us as to why we too are not following the guidance. But as I said, we go through each of these requests individually. They're reviewed generally. If they're not adjudicated in a way that permits the vaccine, it will come to me or Debbie Driscoll to make a final decision about it. But we look at what the laboratory does and the kind of tissue they handle and how they handle it, and make an assessment as to whether there appears to be any risk or not. So the frustration is understandable, but we're making hard decisions about this and doing our best. So I'm sorry that's as frustrating as it is. I am.
Are there excess COVID doses which remain every day if some patients don't show up for their appointments? How can Penn faculty and staff take advantage of that? And is that encouraged?
We're very careful towards the end of the day to try to anticipate what the tail end of the day is going to look like. We try to avoid opening an extra vial if it's going to mean there's 7 or 8 extra doses left over. We try to find people who meet the criteria. We try to anticipate a couple hours out from the end of the day how many more visits we have and how many doses we're likely to need to dispense at the end of the day. We have wasted almost no vaccine in the 2 months that we've been doing this. So we try to find patients at this point who are eligible. But that's really the focus of what we're doing right now. If we're aware of a pocket of staff that sort of en masse have not been vaccinated, we'll reach out to them. but we're doing outreach at the end of the day to contact people. So we're not really opening it up to to people who are hanging out nearby to get the vaccine. We continue to try to do it in accordance with the guidance.
Can you, excuse me, can you clarify if Penn has been given the limitation of vaccinating only Philadelphia residents? What about staff and faculty that live in the suburbs?
We've been, we were instructed that and this was a point of contention in the Vaccine Advisory Committee, and I pushed back very hard on this. We were allowed to vaccinate healthcare workers who lived outside the city, but apart from that, those living outside the city need to be vaccinated with Commonwealth vaccine, so to speak, vaccine from the counties. So we don't turn people away when they show up, but we're not inviting people outside the city to come downtown and get vaccine, which is why we're trying so hard to stand up a site at Radnor. That's, it's really important to us to be able to provide that service. So we vaccinated healthcare workers, but we haven't been permitted to go beyond that.
Oh, that's interesting. So I know that Penn has prioritized high-risk cancer patients for getting the vaccine, but are you saying that's only high-risk cancer patients who live in Philadelphia?
That's correct. All of our patient offers have gone to people with Philadelphia zip codes. Now, there may be some exceptions to that, but that map that I showed you earlier of those are all Philadelphia zip code offers based on the conditions. That's the first cut, Philadelphia zip codes. Yeah.
And for people living in the communities around Penn that you're setting up these vaccination centers for, how is that being publicized? How are those people being notified that vaccine is available?
For the event last weekend, what we did was we met Reverend William Shaw is the chair of the Penn, the HUP Board of Trustees. And we reached out to him and he convened a meeting of about 20 pastors. And we discussed this with the pastors and they expressed interest in participating, having their congregations participate. And then we gave them information about the vaccine and asked them to discuss it from their pulpits the week on the Sunday before the event, and they did so. And we asked them to accept registrations from the members of their congregation. So that's how it was done. One of the things that we've learned is, and I showed you the big delta there between the number of offers that we've made in the city and the percentage of people that have accepted the offers. It's only about 30%. There are many, many people that just don't use email or don't have internet connections. And so, it's really necessary to have, as we call it, a no-tech, low-tech option for getting people registered. So that was the approach there. The next session, probably maybe even the next two sessions, we haven't decided, will be at non-denominational sites because we're trying to bring the Muslim community in, and the cultural and religious issues there make it a challenge to use Christian denominations. So we're trying to be sensitive to those issues.
What is your prediction about vaccinating children below 16 years old?
Well, trials are going on. The trials proceeded pretty quickly in the spring and summer last year, and got us to the point of FDA approval for the EUA by November. So if we can proceed at the same pace, I think that, and I don't see why we wouldn't, I think that by later this year, we might be able to be vaccinating younger adolescents and younger children.
A couple of people have asked if they can get your email address so that they can ask you about their individual lab priority level.
Sure, I'll type it into the chat and you can just look at it there.
Great. Let's see. Has the health system sent a mass communication to patients regarding vaccine distribution? Individual departments and divisions have crafted messaging, but it would be helpful to have a standard message if not already sent.
We do. We've posted messages on our website, and I haven't done. I've certainly reviewed and been, a participant in the crafting of those, but in the posting, I haven't been involved. But I know we've posted several messages reaching out to our patients to keep them informed. I believe some messages have gone through My Pen Medicine, and we've certainly posted things on our website.
Los Angeles has been successful with a walk-in clinic where volunteers help those who have difficulty with internet or insurance verification. Is anything like that being considered for Philadelphia? It sounds like you are addressing that with the local community.
Right. The walk-in is challenging because we've actually had our a phone system and an internet scheduling program crash when we've opened it up, and people just start calling, and we're trying to avoid and logging in. We're trying to avoid situations like they had at the convention center where people get turned away at the end of the day. So our sessions are not walk-ins. You have to pre-register. I'm not sure how the city is doing. The city is still operating the convention center, but I don't think that, I think they have patient-initiated registration, but I don't think they're having.
I can't tell if I just froze or you just froze, but.
Oh, did I freeze?
I think it was my iPad.
Okay. There's a question about whether I see it, did I say the child vaccines may be available later in the year? That was speculation on my part. I don't have solid information, but trials are going on. And what I said was, if they proceed at the pace that the adult trials proceeded last year, that we could have vaccine by the end of the year for younger individuals.
When do you think PenMed will start offering the vaccine to other high-risk conditions included in phase 1B?
We're trying to start right now. We've made enough offers and we have enough capacity that we want to offer to the rest of 1B. And I have to, I had an email exchange with Health Commissioner Farley the other day, and I believe he gave me the go-ahead. But on second reading, there was some ambiguity in his answer. So I need to clarify that. But I think we'll be moving on to 1B within a week or so.
Thank you so much. You've been very generous with your time. This has been wonderful for all of us to get all this information and to ask you the questions. Somebody asked if this will be available. Yes, this is being recorded and will be available at some point on our ASEF website so that you can listen to it or send it on. Again, PJ, thank you so very, very much.
My pleasure. Thanks for having me, Judy.
Thank you.